It is my great honor to be here. Thank you to Dr. Mustafa, Dr. Ahmed, and Dr. Hamdi Ibrahim for the invitation. I also bring greetings from Dr. Cynthia Sears, who is the president of the Infectious Disease Society for America. I told her about this organization and this conference, and she is very excited to hear that there's a new infectious disease organization in Egypt. And then finally, I think it's absolutely wonderful that you are trying to develop and expand the infectious disease fellowship here, because it is such an important specialty, and our training is really quite specialized and very important. And my talk's a little bit different. I'm going to talk about vaccines, which are the ultimate in prevention. If you're talking about antimicrobial resistance or prevention of mortality and morbidity, vaccines are really the way to go. I'm going to problems. I'm going to focus on 4 vaccines that are not part of the regular EPI program here in Egypt. I'm going to start with influenza, which I've been working on for 12 years now. It's a very challenging virus, and the vaccine is also somewhat challenging. Then go to pneumococcus and the pneumococcal vaccine, rotavirus vaccine, and end very briefly on the new zoster vaccine. And I go the wrong direction. So starting with lower respiratory tract infections, this is the leading infectious cause of death in all ages. There have been 2.4 million deaths worldwide in 2016, according to the Global Burden of Disease Study. Pneumonia deaths have decreased for children, but are the same or increasing for adults. And in Egypt, pneumonia is the number 5 cause of death at all age groups, and the number 2 most common cause of death, of premature death in Egypt. Influenza, as I know you have a lot of experience with in Egypt, is both a seasonal pathogen. We have in the United States anywhere between 20,000 and 80,000 deaths every year from influenza, but it is also an emerging pathogen, and there's always new potential for pandemics from influenza. This slide is from Dr. Anthony Fauci, who is the head of the National Institute for Allergy and Infectious Disease. In it, he lists the 20 most concerning pathogens that are potential emerging, and of those, 5 of them are influenza viruses, so this is a really significant pathogen. The influenza virus, here is a picture of it. It is a RNA virus, single-stranded RNA virus with 8 different RNA segments in its genome. On the surface of the virus, there's 2 proteins that are very important. There's the hemagglutinin protein, which it binds to the cells that it infects and allows for invasion of the virus into the cells, and the neuraminidase protein, which allows the virus to escape from infected cells and go and infect new cells. And it's really the hemagglutinin protein that's the main target of vaccines, but there's also more and more interest in the neuraminidase protein. When we talk about influenza viruses, there's not just one virus, as you know. There's many, many different influenza viruses. There's 2 main big groups that infect humans. There's Influenza A viruses. Those are the viruses that cause epidemics every year and pandemics every 10 to 50 years. And then the Influenza B viruses, which are somewhat different but circulate every year, and in the United States cause generally spring outbreaks. And I don't know what the Influenza B seasonality is in Egypt. The Influenza A viruses, they're differentiated by their hemagglutinin and neuraminidase, and that's how we call them. So the seasonal viruses that circulate every year are the H3N2 virus and the H1N1 virus that emerged in 2009. There's also the avian viruses. There's 16 different hemagglutinins and 9 different neuraminidase that are circulating in birds, and they can occasionally cause infections in people. And so Egypt is the most endemic country for H5N1 in humans. There's also H7N9, H9N2, and other avian viruses that have infected people. The Influenza B viruses, although they have hemagglutinin and neuraminidase, that's not how we categorize them. There's 2 big classes of Influenza B viruses. There's the Antibody lineage and the Victoria lineage, and they co-circulate every year. And this is important when we talk about the vaccine. Influenza, everybody sees every year. But this is a virus that causes respiratory tract infections It's a sudden onset disease. It causes fever, causes cough, but it also causes a lot of complications, and especially in the most vulnerable people, so children and people over the age of 65, or people with immunosuppression, and it's really the complications of influenza that are most problematic. In children in the United States, the most common cause of mortality from influenza is not actually respiratory, but it's cardiac from influenza myopathy. In adults, pneumonia is the most common cause, and we see a lot of pneumonia from influenza in the ICUs every winter, and not just from influenza, but from bacterial superinfections after influenza. So we see staph, we see strep pneumonia after influenza, and people often end up intubated in the ICU. And one risk group that I'm going to talk about is the risk of influenza in pregnancy, and that's a major risk factor and the highest priority group for influenza vaccination according to the WHO. There are two major classes of influenza vaccines, but there's many different influenza vaccines that are available on the market. The main class is the inactivated vaccine. This can happen in several different ways. The old vaccine is we would take an influenza virus and we would just kill it with formalin, and then inject the whole virus into the arm. That works really well, but it made the person who got the vaccine very sick. It gave them high fevers, it gave children febrile seizures, and so this vaccine is really not available in most parts of the world. There's some parts in Eastern Europe that are still using the inactivated whole virus vaccine. Oh, I don't know what I just did. I'm sorry. The vaccines that are now available are the split virus vaccine, where we take the virus and we chop it up into little pieces. It is quantified by the amount of hemagglutinin in the vaccine. So it's the only part of the vaccine that's actually measured and that's standardized across vaccines. The other is when we purify the hemagglutinin and the neuraminidase, and we get just purified hemagglutinin and neuraminidase without the rest of the influenza virus. Thank you. The other main category of vaccines is the live attenuated vaccine. There's two. There's one in the West called Flumis, and there's one that comes out of Russia. This is a vaccine in which the virus parent is grown at colder and colder temperatures, and the virus acquires mutations to make it attenuated. It's a weaker virus. It is cold adapted, so it likes to grow at colder temperatures. It'll grow in the nose, and it won't grow in the chest. It is temperature sensitive, so it shuts down at warmer temperatures. So if somebody at 37 degrees, the virus doesn't replicate. At 35 degrees, 2 degrees, the virus replicates. And so when you give this vaccine, you can take the hemagglutinin and the neuraminidase off of this parent virus and replace it with the seasonal hemagglutinin and neuraminidase, and you have a vaccine, a virus, that is live attenuated, cold adapted, and temperature sensitive. You can give it into somebody's nose. It replicates in the nose, causes an immune reaction, and then protects the host from getting influenza infection. But it doesn't go into the chest and does not cause pneumonia. This vaccine actually has been shown to be more effective in children than the inactivated vaccine that we give through injection, but is far less effective in people who have more experience with influenza and people who've had a lot of vaccine or older adults, because the vaccine has to replicate in the nose, and if you have a lot of pre-existing immunity, it won't do that. There are other vaccine technologies that have emerged over the last few years. Prior to about 10 years ago, almost all the influenza vaccines in the entire world were grown in embryonated chicken eggs. So in eggs that are already fertilized, in which there's a little chick growing, you inject the virus in there, the virus grows, and then you isolate the virus and create the vaccine. Now we have a cell culture-based vaccine in which the virus is grown in vero cells in culture without the use of chicken eggs. There are insect line-based vaccines where it's just a recombinant protein that's grown in a insect cell vector, and then it's purified and you inject the recombinant protein, and that's completely egg-free. There are other vaccines that are in development because the egg vaccine, while it's very effective, is not a very practical vaccine for fast response to pandemic, as we saw in 2009. And so there's other vaccine technologies that are currently in development to help speed up the production of influenza vaccines. These can be virus-like particles, using virus vectors such as adenovirus with influenza proteins attached to it, or just RNA, naked RNA or naked DNA, and injecting that in the person and using the human body and the cells in the host to create the influenza proteins to create the immune response to the vaccine. I work on pandemic vaccines, but I'm going to talk about seasonal vaccines because they're far more pertinent to clinical practice. So the influenza seasonal vaccines that are currently licensed are either trivalent, so they have 3 different influenza strains within the vaccine, or they're quadrivalent. They have 4 different influenza strains within the vaccine. The trivalent vaccines have 2 influenza A viruses, the H3N2 and the H1N1, and the quadrivalent and 1B. And every year when they are making the vaccine, they sort of look around and see which influenza A strains are circulating, which H3 strain is circulating, which H1 strain is circulating, and pick one of the B lineages, either the Yamagata or the Victoria lineage, to create a vaccine. Oftentimes, they get the B lineage wrong. So 50% of the time, if you look back over 10 years, the B lineage in the vaccine is not matched to the B lineage that is circulating. And so now we have the quadrivalent vaccines. They have 4 different influenza strains. They have the H3N2, H1N1, and both of the B lineages, the Yamagata and the Victoria. Unlike some of the other vaccines that we give, the influenza vaccine is not as effective. I don't know if you follow the ACIP, but there was just the CDC's vaccine group, but there was just a meeting last week that showed that the influenza vaccine was, for this past year, was very effective against the H1N1 strain, it's very effective against the B strain, and was not as effective against the H3N2 circulating strain because the strains can drift, they can move away from what's included in the vaccine, and so there could be a mismatch. But overall, the vaccine does work, and so this line here shows the efficacy of the influenza vaccine over time, over many different studies, both the A strains and the B strains. And on this side of the line shows the vaccine is effective, and on this side of the line, the vaccine is not effective. And as you can see, for all of these studies, the influenza vaccine is effective. On any given year, it's between 40 and 60% effective, depending on the circulating strains, depending on how close the vaccine is matched to the circulating strains, depending on the immunogenicity of the vaccine and the virus in the vaccine. There's many different things that can affect influenza vaccine efficacy. But even if even though the influenza vaccine is less immunogenic in those who are elderly, it is still a very effective vaccine for the elderly. So this is a study presented a few years ago that looked at, again, many different influenza vaccine studies and the efficacy of the vaccine in those over the age of 65. And again, this is vaccine efficacy here. So anywhere between 10% to greater than 90%. The green is the efficacy of the vaccine against all laboratory confirmed influenza illness. The red is against influenza-like illness, and the blue is against complications, either both non-fatal or fatal complications. And even though the vaccine is less immunogenic in the elderly, it is still somewhere around 50 to 70% effective against influenza-like illness in the elderly, and effective against ILI and complications. There is actually because of the decrease in immunogenicity of the vaccine in the elderly, there's now two different products that are available just for those over the age of 65. I'm just going to talk about one of them. That's the high-dose vaccine. This is a vaccine that has 4 times as much of the protein as the regular seasonal vaccine that we normally get. And when you give it to the elderly, it boosts their immune response, and it's more comparable to the immune response that is seen in younger, healthy adults. And what they found was that the high-dose vaccine was more effective relative to the standard dose vaccine, but 25% more effective than the standard dose vaccine, and also significantly more antibodies to it. The other vaccine that's available for the elderly is the adjuvanted vaccine. It's an influenza vaccine with a oil and water immersion adjuvant. An adjuvant is a protein that boosts the immune response to the vaccine. That also has been shown to be more effective than the standard dose for the adults, for elderly adults. So even though the influenza vaccine is not a perfect vaccine, it's not as effective as the measles vaccine, it still saves lives. They looked at a study of 124,000 adults with diabetes. So diabetes is an immunocompromising condition that puts you at increased risk for the complications of influenza. And the people with diabetes who got the influenza vaccine were less likely to have strokes, less likely to develop heart failure, less likely to have pneumonia, and had a decreased all-cause mortality, 25% decreased all-cause mortality during the influenza season. So it saves lives, prevents complications. Their Haven study has shown that the vaccine protects against influenza hospitalization, 30% in all adults and 37% in the elderly. So even though the vaccine may not be perfect, it does protect against complications and does save lives. And more recently, it's been shown that influenza can really protect against cardiovascular illness and mortality. So it's been shown that influenza virus, influenza infection, can trigger heart attacks, myocarditis, this is because it causes a rupture of the plaque within the coronary arteries and leads to a heart attack. The large meta-analysis of 5 randomized controlled trials looking at the effects of influenza vaccination on cardiovascular events shows a 35% decrease in coronary events, in myocardial infarctions, in people who have received the influenza vaccination. And this is because it decreases both the plaque rupture, but also decreases the demand on the heart that you would see in during an influenza infection. I'm going to switch gears and talk about pregnant women, because this is a very high risk group for influenza infection and a priority group for influenza vaccination. So pregnant women were shown, especially during it was known before the 2009 pandemic, but it became very clear during the 2009 pandemic that pregnant women were at increased risk for hospitalization due to influenza. And the highest risk was in the 3rd trimester, and they were 3 to 4 times more likely to be hospitalized than non-pregnant women. They also had an increased risk of cardiopulmonary disease because of influenza. And in 2009, during the H1N1 pandemic, 5% of the mortality was in pregnant women, but only 1% of the population is pregnant women. So the mortality is 5 times greater than you would expect to see. Influenza is also a risk to the fetus and the newborn. Increases the risk of miscarriages and stillbirths, increases the risk of preterm birth, and increases the risk for small for gestational age. I'm going to describe a study called the Mother's Gift trial that was conducted in Bangladesh. This was actually a study to look at pneumococcal vaccine in pregnant women, and they used influenza as the control arm. So the women received pneumococcal vaccine or influenza vaccine, and the babies received the pneumococcal conjugate vaccine or the HIV vaccine, and they wanted to see if the maternal pneumococcal vaccine interfered with the baby's ability to respond to the pneumococcal conjugate vaccine. I can't actually tell you what the pneumococcal side of the study did, because the control side was the most important finding of the study. So what they found was that the women who received the influenza vaccine their babies were 63% less likely to develop influenza over the first 6 months of their life. So vaccinating the mothers protected the babies. This study has, and this is because when you vaccinate the moms, it creates huge amounts of antibodies to the strains within the vaccine, and these antibodies are transferred actively, not passively, across the placenta. So the babies actually have just as high levels, even higher levels of antibodies than the moms do after vaccination. And over time, those maternal antibodies decrease. And so the babies are very well protected during the first few months of life, but that decreases over about 6 to 9 months of life. This study has now been repeated in many countries and has shown the same effect. So vaccinating pregnant women protects the moms, but also protects the babies. There was another study called the PREVENT study that was just published last year, where there was looked at the effectiveness of the vaccine in preventing hospitalization in pregnant women. This was a multi-center study that looked at women in both the northern hemisphere as well as the southern hemisphere. Looked at 2 million pregnancies. 84% of these overlapped with the flu season. There was the vaccine was 40%. The vaccine was 40% efficacious at preventing hospitalization and 55% in the United States. I'm running out of time, so I'm going to go quick. So vaccinating pregnant women protects the moms against severe illness and hospitalization. It protects the fetus against injury and growth retardation, fetal demise, miscarriage, and death, and it also protects the newborn from the first few months of infection. I'm going to go quickly to pneumococcal vaccines. So the pneumococcus is a normal flora of the nasopharynx. It's most common in children. Illness from it is most common in children and in the elderly. And there's, as you have done in multiple studies looking at the epidemiology in Egypt, there's increasing antibiotic resistance worldwide. The virulence factor is the polysaccharide capsule around the bacteria, and that there are 90 different serotypes of that capsule, but only a few of them cause invasive disease, and the 10 most common serotypes cause about 60%. I'm not going to spend time talking about all of the different pathology that can happen with pneumococcus, but you've all seen it in your clinics and hospitals. There are two main pneumococcal vaccination strategies. The Pneumococcal Polysaccharide vaccine is an old vaccine. It has 23 of the different serotypes within the vaccine, all of them in the capsular polysaccharide. This vaccine is not as effective. It does not prevent nasal carriage, so the bacteria can still live in the nose. It does protect against invasive disease in the person who was vaccinated, but doesn't protect, there's no herd immunity. It doesn't protect the community. And it's also least effective in those who are most at risk. So anybody who's immunosuppressed, in the elderly, or in children under 2, this vaccine does not work. The skip the recommendation. The current vaccine is a pneumococcal conjugate vaccine. This is a capsular polysaccharide conjugated to a protein to make it more immunogenic. There are 2 different vaccines that are available, a 10-valent or a 13-valent, although a 20-valent vaccine is currently in trials. This actually does affect the carriage and does change the population level dynamics. In the United States, all children under the age of 5 are vaccinated with this vaccine. So this is what happens when you give children the pneumococcal vaccine. So in this chart, these are, in the red, are the strains of the pneumococcus all these colors are the strains of pneumococcus that are in the PCV13 vaccine. The gray is what used to be in the what's in the PCV7, and you can see with the introduction of PCV13 in children in the United States, there's a significant decrease in the carriage and the infections of pneumococcus. But it's not just in children. Vaccinating small children decreases the carriage of pneumococcus in those over the age of 65. So invasive pneumococcal disease in adults over the age of 65 decreased dramatically after we started vaccinating babies. And even when we started vaccinating adults, it didn't make any difference. really vaccinating babies changed the dynamic for the entire population. And this is true all over the world. So this is just from South Africa. You can see the serotypes of pneumococcus decreased after in all serotypes, and after PCV7, that's the red, and PCV13, that's the extra strains in orange. Each subsequent vaccination in children decreased the rate of invasive pneumococcal disease. The WHO recommends that 3 doses of a pneumococcal conjugate vaccine are given to children under the age of 2, and there's 2 different regimens that you can give. The US has much more complicated recommendations. These are the high-risk conditions in which people should get pneumococcal vaccine for. And then the Gavi Alliance has really made a huge difference in increasing vaccinations in the poorest countries. But what that has done is really left countries like Egypt out of the picture. So in this, this is the PCV usage worldwide. The high-income countries have the pneumococcal conjugate vaccine as part of their national program. The low-income countries have pneumococcal vaccine as part of their national program, but the middle-income countries like Egypt don't. So out of the countries of the world, 144 have introduced it, 15 have planned to introduce it, and there's 35 countries that have yet to include pneumococcal vaccine in their IDCARE program. Then I will finish with rotavirus. So, rotavirus is the most common cause of watery diarrhea worldwide, the most common cause of diarrheal hospitalizations and mortality in children. There are 4 rotavirus vaccines now that are currently available. All of them are live attenuated vaccines that are given orally. The WHO recommends the use of the rotavirus vaccines in all national immunization programs. And it really makes a huge difference. So this is data from Mexico. This is the number of deaths from diarrhea in children under the age of 1 in pink, and 2-year-olds in blue, and then 2 to 5-year-olds in green. And you can see this peak in the winter, and that is rotavirus. Rotavirus caused the majority of infant deaths due to diarrhea. And when they started vaccinating children in 2007 in Mexico with the rotavirus vaccine, those peaks disappeared. And the diarrhea mortality really decreased. Again, because Gavi is now rolling out rotavirus vaccines to low-income countries, and high-income countries can pay for it, very few countries have yet to introduce it, but Egypt is one of the countries that does not include rotavirus vaccine in its diet. And I'm going to finish here, and I'm happy to talk to anybody about the other vaccines later. Thank you.